She had taken the little purple pill every morning for 7 years. Her doctor prescribed it for acid reflux when she was 62. It worked immediately. The burning stopped. The discomfort resolved. She refilled it without thinking. It became as automatic as her coffee. Her name is Frances. 69 years old. Retired nurse. A woman who spent 30 years educating patients about their medications and believed, reasonably, that she knew what she was taking. She did not know what it was doing to her gut. And she did not connect the progressive digestive sluggishness, the fatigue that had crept in over the past 2 years, the infections she seemed to pick up more easily than she used to, and the cognitive fog she'd started noticing on her worst afternoons. She did not connect any of it to a medication she'd been taking so long it had become invisible. Here is the detail of Frances' story that stopped her daughter cold when she first heard it. Frances's gastroenterologist, the one she eventually saw, asked her, "Does your primary care physician know you've been on this for 7 years?" Frances assumed yes. The prescription had been renewed at every appointment. Of course they knew. But when the gastroenterologist called to discuss her case, her primary care physician said something Frances hadn't expected. He said he'd been renewing the prescription based on the original indication. He hadn't tracked the duration. In a typical practice managing dozens of chronic conditions across hundreds of patients, that detail had not surfaced. And here's what makes that detail matter beyond Frances. A study of older adults taking proton pump inhibitors found that 68% of them were taking the medication for longer than recommended, and nearly half had no documented digestive disease justifying the prescription at all. A separate clinical review found that between 25 and 70% of PPI prescriptions in general have no appropriate indication. Frances was not an outlier. She was the majority. I'm Dr. Ben, and in this video I want to show you something that connects directly to what we've discussed throughout this series, but through a pathway most people have never considered. Your medications may be doing 2 separate things to your brain. The first is the mechanism we've covered before, the direct route through the central nervous system, through acetylcholine, through the anticholinergic pathway. That route affects specific drug classes, and it works through neurotransmitter blockade. But there is a second route, slower, less visible, and affecting a completely different set of people taking a completely different set of drugs. It runs through your gut. And the medications implicated in this second pathway are not the obscure ones. They are among the most commonly prescribed medications in the world, drugs that millions of adults over 60 take every day without any awareness that they are systematically altering the ecosystem that protects their brain. Stay with me. Because the mechanism here is one of the most important things this channel will cover. Do you know what your medications are doing to your gut bacteria? Not to your stomach. Not to your liver. To the living ecosystem of 38 to 100 trillion microbial cells that produces the compounds your brain depends on, regulates your immune system, and communicates with your neural tissue through a direct pathway that runs from your intestines to the base of your skull. A review published in Frontiers in Neuroscience in 2024, examining the effects of the most commonly prescribed medications on the microbiota gut-brain axis, reached a conclusion the researchers described as the central finding of their investigation. All of the drug classes they examined induced dysbiosis. Every single one. Not as a side effect in some patients, as a consistent, documented alteration in microbial composition. The drugs examined: Metformin, the most widely prescribed diabetes drug in the world; statins, the most prescribed cholesterol medications; proton pump inhibitors, the most prescribed drugs for acid reflux; NSAIDs, ibuprofen; naproxen; aspirin, the drugs millions of people take for arthritis and pain; and antidepressants. Taken together, these 5 drug classes represent medications that the vast majority of adults over 60 take at least one of. Many take 2. Some take 3 or 4 simultaneously. And the research is clear that when their gut microbiome effects combine, the disruption does not simply add. It compounds. Now, and this is the paragraph I want you to hear most carefully, let me be precise about what this evidence does and does not show. The research documenting drug-induced dysbiosis is well established. The research linking dysbiosis to brain health through the butyrate pathway, through gut barrier integrity, through neuroinflammation is strong and growing. But the research directly proving that these specific drug-induced microbiome changes cause cognitive decline in older adults is still at the association and mechanism stage. It is not yet at the proof stage. What the evidence does show clearly and consistently is this. These medications alter the specific bacteria your gut uses to produce butyrate, and butyrate is the compound that reinforces your gut wall, reduces systemic inflammation, and directly supports the health of the brain. After 60, when your microbial ecosystem is already less resilient, that alteration is less recoverable than it would have been at 40. That is the piece your doctor may not have had time to discuss. And it is what Frances' story makes visible. Frances' medication list had 3 drugs from the list I just described. The omeprazole she'd been taking for 7 years, a proton pump inhibitor, the metformin she'd started for pre-diabetes 2 years earlier, and the ibuprofen she took 3 or 4 times a week for the arthritis in her knees. A meta-analysis published in BMC Microbiology in 2023, examining 4 studies of PPI users, found that proton pump inhibitors consistently deplete 2 specific families of gut bacteria, Ruminococci and Lactospiraceae. These are not minor populations. They are the primary butyrate producers in the human gut. The meta-analysis also found a consistent decrease in overall microbial diversity in PPI users across all 4 studies. Frances had been systematically depleting her primary butyrate producers for 7 years. Research published in Frontiers in Aging in 2025 confirmed that PPIs alone alter approximately 20% of bacterial taxa in users compared to non-users. Then metformin arrived and added a second-layer research published in the journal Metabolism in 2024 found that metformin-induced microbiome changes, specifically reductions in butyrate-producing bacteria, were associated with changes in cognitive markers. The evidence on metformin and cognition is still developing, but the direction of the data is consistent. Then the ibuprofen added a 3rd layer NSAIDs contribute to intestinal permeability, weakening the gut barrier that keeps inflammatory compounds contained. More permeability, more systemic immune activation, more neuroinflammation reaching the brain. 3 drugs, 3 separate disruption mechanisms, all converging on the same protective ecosystem. Frances, as a retired nurse, knew pharmacology. What she had never been shown, what no appointment had ever laid out for her, was that the medications she was taking for 3 separate and legitimate conditions were collectively restructuring the microbial environment her brain had depended on for 69 years. So here is what the gastroenterologist did. And here is where Frances' story becomes the most practically useful part of this video. The gastroenterologist did not take her off any medications. That is not how this works. Every drug Frances was taking had a legitimate clinical reason behind it. Omeprazole was managing real reflux, metformin was managing real prediabetes, ibuprofen was managing real pain. The goal was never to remove what was necessary. The goal was to protect the ecosystem alongside it. The first thing Frances did was start a high-potency multi-strain probiotic timed 2 hours away from her medications, to avoid drug-microbe interactions during transit. She hadn't taken a probiotic before. She started one the week after her gastroenterology appointment. The second was fermented food, daily. Frances had never been a kefir person. She tried it, didn't love the taste, and found that miso soup, a tablespoon of white miso stirred into hot water before dinner, was something she could manage every night without thinking. That was enough. Consistency mattered more than volume. The third was the conversation her gastroenterologist had with her primary care physician, the one about the omeprazole. 7 years on a PPI. The original indication, acute reflux, had been well controlled for years. Her physician agreed to a gradual taper under supervision, with a low-dose H2 blocker as a bridge. Frances's reflux didn't return. The omeprazole, it turned out, hadn't been necessary for years. The fourth was the ibuprofen. Her physician and she discussed two alternatives: targeted physical therapy for her knee, which she had never tried, and topical diclofenac, a gel applied directly to the joint rather than taken orally, with a fraction of the systemic absorption. Frances started the physical therapy. Within 6 weeks, she was using the ibuprofen far less frequently. None of this happened quickly. None of it happened in isolation. And Frances was careful not to attribute everything she felt over the following months to these changes alone. But 6 months after her gastroenterology appointment, she sat with her daughter and said, "I feel like I got something back. I don't know exactly what, but something." The afternoon fog had largely lifted. She was sleeping more solidly. She'd gone back to the novel she'd been unable to concentrate on for 2 years and finished it in 2 weeks. And then she said what she said to her gastroenterologist. "I spent 30 years telling patients to take their medications. Nobody ever told me what those medications were doing to something I couldn't see. That sentence is the reason this video exists. Your medications are doing more than treating the condition they were prescribed for. They are interacting with the living ecosystem inside you, an ecosystem that communicates directly with your brain in ways that are increasingly well documented and almost never surfaced in a standard 15-minute appointment." Here is the question to bring to your doctor or gastroenterologist. I'd like to review how long I've been on each of my current medications and discuss whether any of them, particularly my acid reflux, diabetes, or pain medications, are affecting my gut microbiome. Specifically, I'd like to know whether a probiotic protocol or dietary strategy would be appropriate to support butyrate-producing bacteria while I continue my current treatment. That question names a duration review, because duration matters enormously with PPIs and many other drugs. It names a specific mechanism, butyrate-producing bacteria, that any physician following the current research will recognize. And it frames the goal correctly, supporting the ecosystem, not dismantling the treatment. In the next video, I want to take a different angle on sleep not about timing, which we've already covered, but about what is happening inside the brain during the night itself. There is a compound that accumulates in the brain during waking hours and must be cleared during deep sleep. Research published in the last 3 years has shown that a habit millions of people over 60 have something they consider harmless. Something they have done for years actively suppresses that clearance process. The research is not yet final, but what it is showing is significant enough that it belongs in this conversation. Subscribe so you don't miss it. And if you take a medication for acid reflux, for blood sugar, or for pain, and nobody has discussed what it might be doing to your gut bacteria, or how long you've been on it, share this with someone who takes the same ones. Not to alarm them, to give them a question worth asking. I'm Dr. Ben. I'll see you in the next one. The information in this video is for educational purposes only and does not constitute medical advice. Always consult your doctor or a qualified healthcare professional before making any changes to your medications, diet, or health management plan. Never stop or reduce a medication without medical supervision.